Hi everyone, my name again is Vincenzo Berghella. I'm the editor-in-chief here at AJOG MFM, and it's our pleasure to give you an update on the December papers. I'm here with my friend Mo. Hi Mo, good to see you.
Hi, nice seeing you, Vincenzo. Hi, everyone. Thank you so much for joining us. I am Mo Mhatre. I'm a maternal fetal medicine specialist at Tufts Medical Center in Boston and the director of the MFM Fellowship at Tufts. We have an exciting assortment of papers to present for you today. For those of you who are unfamiliar with our format, we look through the incredible work that's been presented in this past month's issue, and we select 4 articles that we want to highlight. We try to select articles that are important for counseling or management of patients who are either in your prenatal clinic or on the labor floor. And we also try to identify papers that may be applicable not only to our MFM colleagues, but also to all of the other obstetrics providers who work in the office and on the labor floor caring for pregnant patients. We are going to be using visual abstracts today to do a high-level summary of the paper, but you can see the papers here, and we encourage you to look at them in full on the AJOG MFM website. And we'll have Vincenzo, why don't you kick off with the first one?
Yeah, the first one is about the performance of a first trimester combined screening for preterm preeclampsia in the US, using though the famous Fetal Medicine Foundation computed risk model, which is pretty much used all over Europe, and Nicolaides was behind this. The objective was really to see how well this first trimester combined screening predicts preeclampsia in the US. As you know, it uses clinical history, mean arterial pressure, the uterine artery, PI, and also PAPE and PLGF. Especially, some of these tests are not done as routinely in the US. There's been a question that should we be using this. So they use the data in the New Mom to Be database, over 10,000 patients, of which about over 2% had preterm preeclampsia. And the prediction was decent, the moderate, the area under the curve was 0.75, which is pretty good. It's not perfect, certainly, but it's pretty good. Sensitivity, specificity were also good. So they kind of concluded that this Fetal Medicine Foundation model that is kind of standard, certainly in the UK and in much of Europe, the predicted probabilities were a little bit lower than true event rates, but improved with calibration, which they did, with the data they had. So sometimes I'm very surprised, Mo, how some things are like, so ingrained, and, they do this, all over certainly London and Europe and other places. And in the US, I don't know of any place who does this. Maybe 1 or 2 do, but certainly not most of us. And I thought that this paper was really important. This is from Juliana Martins, I think, is some of the group, multidisciplinary group at the New Mom to Be. Was interesting data to say that this model, like it does well in Europe, also does somewhat well in the US if we were deciding to use it.
Yeah, and I think also it's a little bit challenging because the US population is more diverse. So I think they wanted to see if the same model would apply to the US population. And I think importantly, it has a very high negative predictive value, more than positive predictive value. So it could be helpful for screening out some high-risk patients. Very interesting paper. All right, so for the next paper, this was a study looking at cell-free DNA screening results by stage of maternal malignancy. We know that cell-free DNA has been increasing in its use for aneuploidy screening. And with that, we have maternal circulating DNA in the results, and particularly if there is underlying malignancy in the pregnant patient, that may show up on the cell-free DNA results because there's now circulating tumor DNA. So these kinds of incidentally found maternal malignancy has been a growing part of the literature with NIPT. And this group wanted to evaluate, what is the could you determine the type of malignancy, or at least the stage or the type of malignancy based on the cell-free DNA results? So they did a retrospective cohort study. This was out of Hopkins, looking at patients who were diagnosed with malignancy in pregnancy or within 2 years postpartum. And they were trying to go back and see if those patients had normal or abnormal cell-free DNA results. Abnormal meaning actually showed an increased chance for a specific chromosomal abnormality, or uninterpretable or non-reportable results. What they found was that the really early stage solid tumors were less likely to have abnormal cell-free DNA results. But either if you had a hematologic malignancy or an advanced stage solid tumor, you were more likely to have an abnormal cell-free DNA result for your NIPT. So this is really interesting, and certainly to be mindful of is that those early stage solid tumors were still having normal NIPT results. So not a great way to screen for maternal cancer. However, it would be interesting to see if we could delineate a little bit more of these particular cell-free DNA patterns in the future when trying to assess, someone's type of malignancy or the stage of malignancy. So more to come, certainly a very growing part of research as we integrate cell-free DNA more and more into our practice.
The next paper, it's an editorial actually by Dr. Gulderson here at Jefferson, entitled Pushing the Limit, Antenatal Corticosteroids at 22 Weeks of Gestation. Before I forget, Mo, I want to again thank you for doing such a beautiful job with this infographics, which are great. And I also want to welcome all the people, I forgot at the beginning, who are listening to us to podcast. Now these are shown, live as we're doing now, on Facebook, YouTube, LinkedIn, and X, and Instagram at times as well. But you can also listen us on podcast. And I want to thank our social media editor, Dr. Bonanni, who has kind of made us that a reality. So 22 weeks is kind of the new, we used to be pre-viable. Now I guess it would be really peri-viable. Because of observational data found that survival 22 weeks has doubled in neonates who receive active resuscitations and betamethasone compared to those who only receive active resuscitation. I remember a paper many years ago, Mo, that talked about the fact that, if you're willing to resuscitate a baby at any gestational age, at that point it was probably 24 to 26 weeks. Obviously, that baby has a higher chance of living.
Yes.
With possible mortality, morbidity and mortality. And I think we're kind of moving as, 22 weeks being more common at gestational age, when if you rupture, you give antibiotics and you give steroids, and maybe some people, maybe towards the end of 22 weeks, are offering C-sections and stuff. So everything is shifting. The papers and the evidence which this editorial was reviewing is that once ACOG opened the door saying that, 22 weeks you can offer betamethasone, steroids of fetal maturity, then a lot more pregnancies at 22 weeks are getting steroids than before. Unfortunately, there's persistent racial disparities, which is terrible and should not happen. In fact, this should be opportunities to kind of let that those disparities disappear. We should do the same thing to everyone and act by guidelines. And some of the neonatal, not all neonatal outcomes were evaluated, so we look forward to more and more papers. And obviously, as you know, around the world, there are some survivors at 21 weeks in Japan, but also in the US. And, the needle keeps on switching forward. But I thought that this editorial was very timely, saying that at 22 weeks, more and more of us are not only offering resuscitation, but giving betamethasone and offering, more options to a gestational age that was before thought as pre-viable.
Yeah. And our final paper is on postpartum buprenorphine continuation by initiation setting. So that we all know that opioid use disorder in pregnancy is one of the leading causes of maternal morbidity and mortality. And it highlights the importance of us using pregnancy and postpartum, which is this, particular opportunity where there's a lot of touch points with healthcare and a lot of engagement with healthcare as a way to start patients on medications such as buprenorphine to decrease their chance of overdose and improve perinatal outcomes. And so in the past, buprenorphine in particular was often initiated in the outpatient setting, but this group wanted to look at the difference in continuation rates of buprenorphine in patients who were started while they were inpatient. Because as you know, a lot of pregnant patients are admitted to the hospital for various obstetric complications. So could we initiate buprenorphine as an inpatient, and would that change the chance that they would continue it or discontinue it when they were postpartum? And so this was a retrospective cohort study. This was done at Virginia and Commonwealth University. And this group looked at pregnant patients who had opioid use disorder. And about 76 of them were initiated with buprenorphine in pregnancy as an inpatient, and 38 were initiated in the outpatient setting. And all of these patients who were studied had continued it during the pregnancy and into the postpartum period. And they found that there was no difference in the discontinuation rates. There's also no changes in timing of delivery based on when they initiated this medication or the gestational age that they delivered. And so this was considered, a nice finding to show that use every opportunity you can, whether it's an inpatient or an outpatient. If someone has opioid use disorder and is interested in starting buprenorphine and is a good candidate, you should use that opportunity regardless of where they are to help them make that next step. And so I think this was a really nice paper showing the safety and the good outcomes really in terms of discontinuation rates. It's important to know it was the only outcome they used to look at in terms of opioid use disorder treatment. So it is one limitation of the study, but I think it was nice to show that at least patients were compliant regardless of which setting they chose. And it's a nice way to approach patients when they're ready in all settings in healthcare.
Great, Mo. You had the slide there with happy holidays. Certainly has been a great year, and I want to thank you for the exploration, and I want to thank everyone for listening to us. I don't know if you want to give your happy holidays wishes as well to everyone and close it out.
Yes, everyone. Happy holidays. Happy New Year. Thanks so much for a great 2025. And we look forward to seeing you in January 2026. Take care, everyone.
Bye-bye.